the other things that I just probably would be nice to think about is that, there are many different causes of hearing loss. And, some of them are causes that maybe you don't see at birth.
Seems like I'm going to answer the next statement based on everything that you have said. A baby is born with normal hearing. We don't need to worry about hearing again. Myth based on...
If hearing loss runs in the family, it can never affect the child unless parents have obvious hearing loss.
That is a...
Hi, and welcome to Conversations with Speechies. I'm Pooja.
Hi, I'm Alicia.
Hi, I'm Merin. In today's episode, we are going to be talking about one of the foundational skills in a child's development, hearing, why it's important, and how it impacts speech and language development.
In our work as speech and language therapists, we often get referrals of kids who may have unclear speech or speech delays or listening challenges among so many more. And one of the first areas that I ask parents about is hearing, because like you said, Merin, hearing is so foundational to speech and language development.
And children learn to talk by listening to others talk. The first stage of listening is hearing. So at birth, and in fact, even before that, so from birth and even before that, a baby is listening to voices, words, tone, rhythm, and that's how the brain develops speech sounds and attaches meaning to words. If hearing is affected, then access to auditory information is impacted.
Yeah. And as you're saying this, Alicia, hearing difficulties aren't always obvious. Sometimes it can be temporary, like fluid in the middle ear or some middle ear infections, and even sometimes cough. All of these can impact how a child learns, listens, and communicates confidently, especially in their early years. That is why it's important to do hearing assessments and sometimes even monitor them if required.
And Merin, that's why hearing screening is important right from the newborn years, and it continues to remain important up to the childhood years, right? And today we want to discuss this topic a little further. So I'm excited because we are going to be joined by a pediatric audiologist. Her name is Sandie, and Sandie works at the University of Georgia. Her current research is in the field of audiology, where she talks about, or she's studying the impact of middle ear infections like otitis media on vocal and auditory development. She also specializes in newborn hearing screening and pediatric hearing care. So we welcome her and let's ask her questions and get to know this area better.
All right, Sandie, let's begin with something fun. Let's do a round of fact or myth. So we're going to read out some statements to you. You tell us if you think it's a fact or a myth and why. Okay?
I'm going to go first. Hearing is foundational for speech, language, and overall brain development. Is it a fact or a myth?
That is definitely a fact.
Okay. Would you care to explain why?
Oh, sure, absolutely. Well, when we think about how the ear develops, the ear actually is structurally developed in the first 20 weeks gestation age, so in utero. And then when an infant or a fetus is 25 weeks gestation age, then the ear is fully functional. So actually, the fetus is receiving auditory input before it's even born. So the neurosensory portions of the ear are continuing to develop, from like 25 weeks gestation all the way to 5 to 6 months. So an infant, a fetus at the fetal level is receiving input and learning, even early on to appreciate their native language, the sounds and the environment, their mother's voice, and some other frequencies that they're able to respond to. And I don't know if I could continue on, but it's actually very interesting in that, infants, or I should say the fetus before it's born, is even able to respond to very low pitches. So like men's voices, vowel sounds, and then at around 27 weeks gestation. And then as the fetus gets to about 32 weeks gestation, it is able to respond to more high frequency sounds. So some of the speech frequencies, higher pitch frequencies. So, and there have been some really exciting studies that have been able to document that. So it's definitely important, even at the very earliest period in time for hearing, for babies that are going to speak, be oral, for oral language, that they're able to hear even in utero. And that leads into lots of questions about newborn hearing screening and why those things are important, which I'm sure we'll probably talk about in a moment. Yeah.
Yes. So you mentioned newborn hearing screening. Tell me if this is a fact or a myth. Yeah. My statement to you is newborn hearing screening is just routine paperwork. It doesn't really change much.
That's definitely a myth. Newborn hearing screening has been, I would say the concept of that has been in development since probably the 1960s. In the States, in the United States, for example, even in the 1960s, people were interested in determining if a baby could hear right after they were born. And so there was a whole process of determining, what are the risk factors for hearing loss? Can we just screen babies who have a risk factor? And it turns out that about 50% of children who are born with a hearing loss have no risk factors. So it is crucial that we're able to screen babies, ideally shortly after birth, so that we can detect hearing loss and then make a plan for intervention and for communication, regardless of whatever communication modality it is. So, and lots of research and evidence to support that if we're able to detect hearing loss at the youngest of ages, then we can ensure typical language development, all other things being equal, of course, based on the baby's development.
How early can you detect hearing loss?
We can detect hearing loss at birth, actually. So, it's not recommended to screen the baby before they're 24 hours of age. And that's because you still have birthing debris in the ear canal. It needs a chance to kind of work itself out. If a baby's born by C-section, maybe at, 48 to 72 hours would be better to give the fluid a chance to come out. But we have technology now, 2 different kinds of screening technology that are really simple. They don't hurt the infant. We put we put a little probe in the baby's ear, like a little earphone, and we present a series of sounds. It's called otoacoustic emissions. And if hearing is within the normal range, we can get a response within, anywhere from like 30 seconds to maybe a couple of minutes if the baby is nice and still. So that is a really fast, efficient way. But if there's birthing debris in the ear canal, this is why we have to wait. Then that can interfere with the ear being able to detect the signal. And then there are other kinds of screening that we use called auditory brainstem response screening. And that involves attaching surface electrodes to the baby, similar to like if you're having your heart rate monitored. It doesn't apply anything to the baby. It's just to pick up the brain's response and put a little headphone on, and then we can monitor how the brain responds to sound. And we can do that, right away, the same kind of, 24 hours to 72 hours right after birth. And we can determine, and at that point, it really is a screen. And so if a baby passes the screen, then we can say that hearing, at least on that day, is within the normal range. If they don't pass, then they need to have a rescreen within about 2 to 4 weeks. And that, again, has to do with, maybe there was fluid still in the ear, or maybe the room was extra noisy, or the baby was, very fussy, or maybe the parents, didn't want to stay in the hospital much longer. So there are reasons why. And then when they come back for a rescreen, if they do not pass that, then there's a diagnostic test that's done, and that is a a more extensive auditory brainstem response test, usually in combination with the otoacoustic emissions. And that's where we can actually determine, how much hearing loss is present, what frequencies, and we can maybe talk a little bit about the speech frequencies. Our ear is responsive to lots of different sounds, and we can determine the degree of loss at the individual frequencies, and then we can make our hearing aids responsive to that hearing loss. So
it's lovely.
yeah.
It tells me that newborn hearing screening in those newborn years is so critical, and it's not merely a tick mark that the hospitals have to do before they discharge the babies. And even following up is so critical, right?
Yes.
Is it only for newborns, or hearing screening across and through childhood is also important?
Hearing screening throughout childhood is very important because, again, hearing loss can develop at a later time, and it can be the type of hearing loss that is a permanent hearing loss, like a sensory neural. So there's some damage either to the cochlea or to the nerve, or it can be a temporary hearing loss, maybe due to an ear infection. So it is important that you have some, I think, milestone screens. So maybe you think about screening a baby, definitely at birth, and then maybe at preschool, kindergarten age, third grade, around those times would be very good marks for screening. And then, of course, educating the family that if they notice a change in hearing, that they seek an evaluation, or if the baby is not developing the early speech sounds, the canonical ba ba ba, ma 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 kinds of sounds, and that would be an indicator for a check as well.
So seems like I'm going to answer the next statement based on everything that you have said. If a baby is born with normal hearing, we don't need to worry about hearing again. Myth.
That is absolutely a myth. And, one of the other things that I just probably would be nice to think about is that, there are many different causes of hearing loss. And, some of them are causes that maybe you don't see at birth. A baby could be exposed to an infection in utero when it's developing, things like some of the infections like herpes or syphilis, or even CMV, cytomegalovirus. I don't know. That's really kind of a big one right now, similar to the common cold, but we find that can be associated with progressive hearing loss over time, and probably accounts for many of the cases of unknown hearing loss. So there certainly can, and there can be, genetic causes of hearing loss that aren't able to be detected at birth, simply because hearing is normal at birth, and then over time, hearing can progress. So it's definitely an important thing to do, to continue to monitor. Yeah.
How common are these causes of hearing loss found in children? Like, I know we spoke about common cold or middle ear fluid and infections like that. But is hearing loss more common than spoken about in children? How is it like?
Well, again, kind of referencing what my experience in the United States is that hearing loss you can have maybe 2 to 5 children per 1,000 born with hearing loss and evident at birth. So that doesn't even account for hearing loss that can happen at a later time, and we can talk about that in a moment. But whenever you have populations of mothers who maybe don't have good health care, prenatal health care, get exposed to certain infections and other kinds of things, then those numbers can go up. But it's pretty routinely 2 to 5 per 1,000. But again, and high-risk populations where maybe access to medical care or you get medical care late, then you might expect that those numbers can be higher. And that would be for that permanent type of loss, so the sensory neural loss, where there's actually, it's impacting the cochlea or the auditory nerve. So we call that a permanent loss. Then there are instances of temporary loss, and otitis media, that's the common ear infection. That is very, very common. And, there are some interesting studies that look at if you get your first ear infection before you're 6 months of age, then you're more inclined to have more ear infections than if you get your first after 6 months of age. But something like, 90% of children have at least one ear infection by the time they're like 6 or 7 years of age. And many of them have multiple ear infections prior. And those ear infections can cause anything from a mild to a moderate hearing loss, which can definitely impact your ability to pick up those important sounds of speech and learn how to develop speech. Or even if you're a child that, has already developed the speech sounds, but you're in a classroom, if you're sitting there with a mild, moderate hearing loss, think about, plugging your ears with your fingers or putting in, earplugs and then trying to hear what's happening in your classroom and learn. It's very difficult.
Also, Sandy, I remember reading somewhere that the anatomical structure of the ear also determines how frequently you can get ear infections. Some structures are more prone to ear infections than others.
Yes, that is true. My reference point would be like Native American populations, for instance, because of structural differences in the angle of the ear canal or the anatomy, certainly have a higher incidence of ear infections, and so there's a range of humanness, and so certainly if there are certain like structural differences, the way the eustachian tube is angled, and so that's a really important structure in the ear because that allows the middle ear to get fresh air in there, and so for lack of a better word. And so the eustachian tube, if it's depending upon how functional it is, if it's small, the angle of the eustachian tube, that can sometimes impact how well we're able to keep that space healthy. So there are many other kinds
as you're
of
talking, you spoke about like permanent hearing loss and temporary causes which are due to ear infections or other reasons. Like everybody knows that, okay, if there is a permanent hearing loss, there are hearing aids and cochlear implants and other devices available. But when it comes to temporary hearing loss, what can parents do to support the child when they are going through that phase? Of course, you treat the infection and then the hearing comes back. But what to do in that phase when the loss is present?
That's a very good question, and very relevant question too. So first, I would say I think it's important for parents to keep track of how often these ear infections are happening, because there are some medical interventions like pressure equalization tubes, where you can get tubes, and that's usually for kids who have chronic ear infections. So documented, like, again, I'm not a medical professional, but maybe 3 ear infections over a period of like 3 months can sometimes be considered chronic. So in those cases, you certainly would want to pursue probably the medical management, particularly if the fluid is in the ear constantly, and that can prevent some other kinds of conditions. Like I think we've talked about, like getting pus or sort of a thick glue ear kind of a situation. But in terms of just sort of those maybe here and there kinds of ear infections, I think it's important for parents, depending on the child's age, to make sure that you're maintaining a good proximity to your child. So, for instance, if it's an infant, you're lucky enough to have an infant who gets their first ear. This is not lucky, but you have their first ear infection, before 6 months of age. Maybe a common place that you're carrying them is, like strapped on or holding, and then you have that like close proximity, so they're able to see your face, and the auditory signal that reaches their ear is nice and loud. Teachers can put children toward the front of the class, so they have preferential seating. And some children who get them a lot, like children with Down syndrome, who, because of craniofacial differences, may have chronic ear infections. They can also fit like and I don't know what you would call it here, but like an auditory trainer. So it gives a little extra boost. They wear a microphone and a little headset, and so it provides some mild amplification of the signal. And so that can be done, with an audiologist or just a very low gain, and that helps them to pay attention.
Like low gain hearing aids, which are temporary in nature.
Right, and that helps them to maintain attention, particularly with the chronic nature of how some ear infections can be.
Or just looking at the child speaking a little louder, giving that visual information.
Naturally louder,
Yeah.
naturally closer, lots of visual information, absolutely.
So there's one more fun fact or myth. If hearing loss runs in the family, it can never affect the child unless parents have obvious hearing loss.
That is a myth. So again, there are so many different causes of hearing loss. One of the risk factors for hearing loss is a family history of early onset hearing loss. So it wouldn't be, I always, when I ask my families that I work with, is there a history of hearing loss? I always qualify at a young age. That is not an ear infection. So, so that is a risk factor, but in fact, 50%, again, looking at the group from the States, 50% of children who are born with a hearing loss have no risk factors. And so that would include a family history. So, so there are so many other variables to look at. Family history is a risk factor at a young age, but 50% of children who are born with hearing loss at birth have no risk factors that we know of.
What about geriatric hearing losses? Does that impact hearing?
Which type of hearing loss?
Like geriatric, like hearing in the old age?
Okay, so hearing loss in old age? No, we would think about that completely different. So it's a normal process of aging to develop hearing loss. Not everyone who ages develops hearing loss in the same rate, and there are people, in their 80s or 90s or whatever you want to classify as old age who do not have hearing loss, but it's very normal. It's called presbycusis is the name for that. And if grandma or grandpa have a hearing loss, that would not be an indicator for the child. So that's just kind of a different, due to changes of aging, degeneration of the cochlea, and things that just normal processes of aging. Yeah.
Okay. Now I have one more statement for you. Tell me if it's a myth or a fact. If we introduce sign language or alternative augmentative communication devices or other modalities that are not oral language, it will stop the child from developing spoken language.
That is a myth. And I actually have a research study that I worked on early in my career that looked at that. So it's important. I think the most important thing that families need to think about is giving a system of language and communication is the most important thing that you can do, regardless of what that modality is. So signing and speaking to the child will not keep them, just providing that extra sign support or augmentative will not keep them from learning to speak. Now, that assumes that people are still talking to the child and that the child has access to audibility. So, if I'm a child with a moderate hearing loss and I have hearing aids on, but I'm needing extra sign support and people are signing and speaking to me, that does not prevent, speech development. And in fact, we found that children will continue to use the sign for as long as they need it, and when they no longer need it, it tends to drop out. Now, that would be sort of a different situation than maybe a family who is, do you use the term like deaf culture, like a family who is, has a long-standing history of deaf culture. So maybe, they're using Indian Sign Language, and that's like their main mode of communication. And so, some of the considerations for language development might be a little bit different, but absolutely you should provide any and all supports that a child needs in order to develop communication first, and then if the goal for families is oral, speech, then absolutely you don't have to be worried about signing or augmentative systems interrupting the speech process. Yeah.
Thank you. That clarifies a lot for so many parents who have questions like, if I'm going to sign or provide a device, my child is never going to pick up oral language when the child has access to auditory input.
That's
of
right.
course, it's different when there is no access to sound, right?
Yes. Yeah.
And even in speech therapy, when we work with children who are nonverbal, our first goal is to give access to communication. Speech is always a byproduct. If that comes, that's great. But giving access to communication, and we use different modalities to allow the child to communicate and access communication.
And you want them to have language. So everything stems from language, regardless of what the form is. So you need to give them that input. That's really critical.
And there are so many babies at a young age, whether neurodivergent or neurotypical, where before the baby learns to speak, the parents teach them signing so that at least there is some communication channel that is established, and it's very important.
And it helps them to express their needs and wants, and it's just it's a very important part of development. So yeah, I would definitely.
So I
encourage
exposed my son to signing very early. Like he's 12 now, but when he was born, I showed him signs for more, give me more, and we used pointing, and I feel like that kind of helped for language to come.
Yeah, and babies actually, so I did the same thing with my daughter, and they can actually express their first words earlier with sign language. I mean, you can have baby signs as young as 6 months of age where they're, starting to show some, I want more, or I want to eat. And, whereas for, oral first words, usually that's somewhere around, a year old, not including canonical babble, the ma, 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 ba, 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 which are some of those critical early sounds that babies make. And we want that to be mama and dada, and that, and that's that they learn that too. But yeah.
And that's why we emphasize when speaking to caregivers so much that these alternative mediums are actually just aiding the language development and not really stopping them from learning speech and language.
Yes, absolutely.
This was so interesting, Sandie. But we have some more pressing questions for you, which we would love for you to answer. So, what are some early indicators of hearing difficulties that caregivers and parents can watch out for? Of course, there's some obvious ones, but also tell us about the subtle signs that one can look out for.
Absolutely.
To kind of identify that there might be something off with the hearing.
Well, I would say one of the very first things, and I conduct a lot of my research in this area, has to do with that development of what I call canonical babble. So canonical babble is a very important milestone. It's a universal milestone. Babies follow sort of a universal trajectory for early speech development. So, they start out with those kinds of reflexive sounds, like, they're cold or they're hungry and they might cry. And that's just like between 0 and 2 months. And then as they get, they'll start those pre-canonical sounds where they're starting to coo, they're starting some basic vowel productions, they start to experiment with their voices, like between 4 and 6 months of age, growls and trills and, all those fun sounds. But then canonical productions, so that's a, production of a true consonant that sounds very mature, it sounds adult-like consonant vowel. That usually develops between 6 and 10 months of age. And there's a window there. There's a reason why canonical syllables, that consonant vowel, doesn't develop earlier than 6 months, and that's physiological reasons and the orientation of the vocal tract. The baby grows, and as the baby grows, they're able to support some of those productions of canonical syllables, consonant vowel production. So that's like ba ba ba, ma ma ma, d d d, do, any of those combinations. If a baby does not develop canonical babble, I would say by around 10 months of age, and sometimes, there's a little bit of a window, maybe 11 months, but that is a red flag. That is a cause for concern. And we routinely see that children who are deaf or hard of hearing, maybe children with speech motor disorders, some other kinds of developmental conditions. If you don't see canonical babble develop in that window, definitely by 10 months, I would start to be concerned, and that would be an indicator that you should have a hearing screen. If hearing tests normal, you might want to get a speech language pathology screen for maybe, some of those early indicators for like a speech motor disorder. And so that the research has really, really supported that. So if the takeaway message for any, new parents out there, I would say, you want to really look for that development of those canonical syllables, that's very significant. And it's an indicator that first words are around the corner, that first words are coming. So that would be something. Also, you can think about some of the auditory skills that children develop. We learn how to detect sound and to tell if sounds are different or discriminate sounds and recognize sounds. And so there's sort of a normal trajectory over the first 2 years of life that babies are learning how to, localize and respond to sound. So if parents are noticing that they're, within like 18 to 24 months of age, if they're not, showing some of those interest in sounds, lullabies, discriminating, mom's voice from maybe like a dog barking or those kinds of things, then that would be another indicator. Or anytime there's a change in the way that the baby responds or the young child responds, if it seems like they're not hearing as well as they were before, that's an indicator.
A lot of time parents do come saying that, he used to do it when he was 15 months old or 12 months old, and then I suddenly see a disappearance of skills or regression of skills in my child. Of course, the causes could be so many and varied, but they do see the regression sometimes.
Right. And that again would be an indicator for a hearing evaluation as well as like a speech language evaluation. Absolutely. So those would be the things that I would, encourage parents to look out for. Yeah. And anytime they have a concern, that's one of the sort of the things. If a parent has a concern, they should feel comfortable voicing that to their teachers, to the pediatrician, to their physician, that they really, because they know they're around the baby, the young child more than anyone. So they really do
instincts.
Trust your instincts. Absolutely. Yeah.
Sandie, you mentioned about how children detect sounds versus how they understand and process language. So many caregivers say that my child can hear, but I don't know if they're listening. They don't really pay attention to what I'm saying. How do you make them understand the differences between detecting sounds versus, understanding and processing speech and language?
Yeah, that's a really good question. That's a complicated question, but I think the way that I would tackle that is to think about what is speech. Speech is very complex. It has multiple frequencies or pitches. So, it's got low pitches, so 250 hertz, 500 hertz where men's voices are, vowel sounds. And then it has, high frequency sounds. So like, some of the speech sounds like, like ch, sh, those kinds of sounds. And then humans can respond to sounds even lower. So like at 20 hertz, 20,000 hertz, but speech has evolved to fall between about 250 and 8,000 hertz. And that's where the human ear is most responsive. The human ear has the lowest or the best ability to detect sound between 250 and 8,000 hertz. So that's a really important thing to note is that speech is complex and has multiple frequencies. It's not just a one tone that we hear. So when we think about that, it is possible for a child to have, or an adult, anyone to have some hearing in one frequency region, like let's say in the lows, but not necessarily in the highs. But when you're, speaking, because speech has, complex multiple frequencies, they may be able to respond or to detect where their hearing is better, but not necessarily. So they know it's there, they're aware of it, but maybe not necessarily understand or be able to perceive sound because the remainder of their hearing loss can be, quite significant. So that's a common thing that happens. A mom might come in and say, I asked, do you think he has a hearing loss? And she'll say, no, he seems to respond to me. He seems to be aware. But in some cases, it turns out that yes, he does have some hearing that's within, a normal range, but the rest of the hearing is not. And he's able to use that hearing that is still within the normal range to be able to detect, but not necessarily enough to, to learn to speak, to learn to, perceive and understand all the complexities, of speech, because you can't just only hear certain frequencies and be able to hear speech. So, and there also are things like, I know that this is probably not the extension of the topic, but when we think about types of hearing loss, we've talked about permanent sensory neural loss. We've talked about the temporary hearing loss, like an ear infection. There's also something called auditory neuropathy spectrum disorder that, as audiologists, we didn't used to look for, but it turns out that there, and this is a different kind of a hearing loss where you may be able to detect sound, but there's a breakdown in the synapse. If you think about how we hear, we have little hair cells, responsive hair cells in our cochlea that pick up sound, and then they send them to the auditory nerve. And with auditory neuropathy spectrum disorder, sometimes you can have a breakdown between where the hair cell, the sensory receptor, communicates with the nerve. That has a very certain audiological profile, so we would need both otoacoustic emissions and auditory brainstem response testing to be able to determine if that type of hearing loss is present. And so that's another kind of situation where, very different than what I was talking about before.
So which means that if parents are observing their child, or if an audiogram or a hearing test is done, it may appear normal, but then the other tests would determine that why the child is not processing or
That's
understanding the language or discriminating between words.
Yeah, and we're still trying to understand the how common that is. It's definitely not that common. So it's not as common as, like a conductive loss where you have an ear infection or a sensory neural. But it certainly is something that we look for, particularly for babies that are in the neonatal intensive care unit for like 5 days or more, that have been on mechanical vents, have had, hyperbilirubin anemia, some of those really complex medical conditions. There tends to be a higher incidence of auditory neuropathy spectrum disorder in those children. So as an audiologist, I would only screen those babies using the auditory brainstem response, because it's going to give me the best detection of if a hearing loss is present, and then we would follow up with some other kinds of testing. So little.
That was great. That gave us so much information. I'm sure it's going to be helpful to so many listeners out there. Okay, so you did give us a brief understanding of what happens during a hearing assessment, but lot of parents are anxious when we tell them go get a hearing test done. They don't know what really happens, especially when children are involved. So can you explain in brief what a hearing test for a child looks like?
Okay, so depending on the child's age, will determine what kind of a hearing test the child has. We talked a little bit earlier about the newborn hearing screen, and that is just a really non-invasive. The baby doesn't do anything. The parents are, if it's done in the hospital, the parents are typically present. So that's just looking for those, brain responses to sound. When the child is about 6 months of age, we do what's called visual reinforcement audiometry. And oftentimes the parent is a participant in that, so you can kind of, go in and see how that works. But what we do is the baby sits on the parent's lap, and we teach the baby when they hear the sound, they turn, and then they get a visual reinforcer, either a toy that plays, or maybe, on a video screens these days, everything has gone video, we might get a reinforcer. But we basically teach the baby when they hear the sound, they turn, and they get a reinforcer.
It's a non-invasive.
Non-invasive. And we're able to do individual ear testing. So we can put little earphones in and test each ear separately, or we can do it with a speaker in the room. And that gives us at least an idea how, if there were a difference between the ears, if the child's hearing within the normal range. So that's a very, very simple kind of thing. We would also then follow that up with what's called a tympanogram. So we want to know how the eardrum is moving. Is there any fluid in the ear? Is there a blockage in the ear canal? And that's simply, we look in with an otoscope. We put a little probe in the ear, and we change the pressure. It doesn't hurt, and the child can watch a little screen, and we talk about drawing a picture of the ear, so we can do that. Otoacoustic emissions we would do as well, just to give us a very full picture. And we may also do some speech reception threshold where we, talk to the baby, and when they, out of the different speakers, or when they hear us, they turn and the sound lights up. And sometimes babies are more responsive to hearing speech. So that would be like a 6 to maybe 12-month-old or 18-month-old, we might assess like that. And then, depending upon the child's abilities, then we would do what's called conditioned play audiometry. And that is usually, it's all play-based. They have headphones on or insert earphones on. And we teach them when they hear a sound, they drop a block or they put a piece into a puzzle or they're building a tower. And, it's a game-based kind of thing. And so we're still, in all of these ways, we're still looking for those individual frequencies that make up speech. Can the baby hear or the young child hear within that normal range? And then, of course, as they get older, then it's more like a typical adult evaluation where they raise their hand when they hear the sound. So there's always a behavioral assessment unless you're an infant, and that's those physiological ABR, OAE. And there's always an assessment of the middle ear. How is the eardrum moving? Do we see any blockage in the ear? And then also we try to get some information on how they're processing speech. But it's really it can be quite fun. Sometimes with a young child, it may take a couple of visits, depending upon how the child feels. If they're tired, they get a little bit cranky, or if they're sick. Those kinds of things can limit the kind of testing that we can do. But with a good pediatric audiologist, usually they can get a lot of information in one visit.
Thank you so much.
Yeah,
That was very insightful, and we got so much understanding not only about the causes of the loss, but how important hearing is to overall development. So thank you, Sandie.
Thank you. Okay.